This is the full interview with Dr. Peter Clarkson, and there are two parts to it. In February 2024, we made our first video about how hard older athletes should train for heart health. It has had more than 1 million views, and it's used on NHS Highland's website. Dr. Clarkson is an NHS cardiologist at Raigmore Hospital in Inverness in the Scottish Highlands. We spent ages discussing follow-up videos, and we've ended up with two. The first is how anyone should assess their own cardiac risk and the decision whether or not they should take the drugs statins. The second video is about returning to exercise after a heart attack or being diagnosed with atrial fibrillation. So that's how we divided up the interview I did with Dr. Clarkson. And I know some people are particularly keen to hear the full source material. They don't want my edits or explanations or pictures. They want to hear directly from the doctor. So that's why I'm making this available as an audio podcast and also a full video podcast on the Always Another Adventure sites. There are links in the show notes and video description. We're going to start the interview by explaining the goal of the interview.
I guess the bits I wanted to cover today and I thought were relevant to a general audience is looking at people who've had some form of cardiac diagnosis and what you do in terms of continuing exercise, what you do in sort of modifying things for the future with people who've already had a cardiac problem diagnosed. And there's a huge range of cardiac problems. There's textbooks in cardiac disease, but I think the ones we should concentrate on are coronary artery disease and probably a little bit about atrial fibrillation. And I think we can split the coronary artery disease into two groups, which is people who've been picked up as having some abnormality in the coronary arteries, but they've not had a cardiac event. And cardiac event means haven't had a myocardial infarction, or in layman's terms, a heart attack. And then looking at the group of people who may have had a cardiac event, people who've had a small or medium-sized heart attack in the past and wanting to get back to doing some exercise. And I think they're probably the main groups we should chat about today, Simon.
Okay, because this is important because could you give me that figure of the coronary artery disease and sudden death?
Yeah, so the bit we worry about is sudden death, and in people who, in athletes, and athletes we use that in a broad term of people who are undertaking regular exercise, we know that people who have sudden cardiac death in middle age, 80% of it is down to having coronary artery disease. And obviously that's the bit we want to try and reduce the risk of people presenting with sudden death. And it's how we structure and how we do that in people who are already known to have cardiac disease. Now, some of the sudden cardiac deaths, that can unfortunately be the first presentation. So people may be completely unaware they've had any problems with the coronary arteries and they present with sudden death. Now, there's not a lot we can do about that, but there's also the groups of people who are known to have some degree of coronary disease and what do we do to reduce the risk of sudden cardiac events in the future.
What are the suggestions that they might have had that might be a diagnosis or it might be something else that they could be at risk of having an event?
So there's people who've got conventional risk factors, people who don't know they've had any coronary artery disease, they've never had a diagnosis, and people if you've got hypertension, if you're a smoker, diabetic, we know you're more at risk of developing atheroma. And that's a primary prevention, no knowledge of having previous disease, that people then seek medical help to reduce their risks in the future. I think the bits for me as a cardiologist is mostly people who've already had some form of diagnosis. And we're increasingly seeing people who've had, for instance, CT scans, cardiac CTs done as part of a well-man or well-person check, and it shows there's a degree of coronary atheroma. And these people are coming to see more of us in clinic to have discussions about what we do with their hardening of the coronary arteries. I think if we go back to the previous video we've had, we recognise that there is a small increase in coronary calcification in people who undertake regular exercise in particular groups. There's also a lot of athletes who have conventional risk factors. You know, a lot of athletic people in middle age, some still smoke, There are some people who've got high blood pressure, high cholesterol. There's diabetic people amongst them. And in people who've got cardiac CTs that have coronary artery disease, we start looking at, is there something we can do to modify the process and reducing the amount of atheroma you have in the future?
Because in the last video, you said you recommended against having a CT scan. That's still part of the advice we give on a screening level. It's not go to see your doctor and say, can I be screened for...
No, this is UK advice, and and I know it does differ, but
we have a lot of viewers in the States.
Internationally, it does differ, and in the UK, our standard advice is we don't recommend CTs as part of coronary screening.
But you're seeing more and
but
more people
we still see people who've gone privately to have CT scans done and been investigated.
And do they pick up? Yes, they pick up the calcification. Do they also pick up the soft fatty plaques that we hear a lot about?
Not a standard CT. There are CTs we can do. So we can do a CT calcium score, where we're just looking at the amount of calcium in your arteries. You can do a CT coronary angiogram, which does pick up the softer plaque as well. And for most people, the screening test is the calcium score. So we have an idea of how much calcification there is in your coronary arteries. And that's actually a pretty good indicator. It doesn't show you all the soft plaques in your coronary arteries, but it's a good indicator of how much coronary artery disease you have. And it can place a number on the amount of coronary calcification people have.
So while we're talking about numbers, so these are people who've had some sort of a diagnosis of this. There's an easier way in many ways to get a kind of an important diagnosis, and that would be to do with the stuff your GP can do, because you might find out about cholesterol and blood pressure. Could you just talk to me a little bit about them and how they then feed into this Q score thing?
Yeah, so there's a Q risk score, which you can get online, which is a calculator which will give you an estimate of what your risk is of having a coronary event in the next 10 years. And that plugs in things like your age, your sex, your cholesterol, your blood pressure, where you live, that goes into a Q risk score. And it comes out with a number at the end of it as to what your risk is of having a coronary event in the next 10 years. Now, in the UK, we don't think there's a lot of incremental benefit to having a CT calcium score on top of that, because the Q risk score helps refine what we should do. Now, it's a useful tool because it helps us guide our discussions with people as to what risk factor modification you want on top of it. So, for instance, quite a lot of relatively healthy middle-aged men, when you plug their details into the Q risk score, may have a risk of about 10% in the next 10 years of having a coronary event. Now, we can use that to inform discussions about whether you want to be on drugs like a statin or not. We know that with statins, if you take statins, reduce risk of coronary events. It probably doesn't seem to make a great deal of difference what group you're in, but they will reduce your risk of coronary events in the future by about 25%.
When you say what group you're in, you mean if you're in a high-risk group and you've got a 25% or 30% or 40% risk of having an event, or a 10% group?
That's right. So they lower your risk. So if your risk is 1%, you'd be pretty lucky to have a 1% risk of having a coronary event in the next 10 years. Being on a statin will lower that by 25%, so it lowers it to 0.75%. So you're actually only lowering it by, in total, 0.25%.
Right.
Whereas
so
if your risk
10%
was,
risk, you're
if
down
your risk
to
was,
7.5.
yeah, so 10% risk, it's down to.
But if it's a 40% risk,
totally, yeah, that it lowers it to 30%. So you can have discussions about how useful it is to be on a statin. Now, I know that a lot of it is the standard advice is that. And it's easy for us to suggest people should be on statins, but that's not a full conversation about discussions and risk. Yes, that will lower your risk, but I think a lot of people want to know how much risk modification there is. So if, for instance, I'm 58. If you're a 58-year-old man with a 10% risk per annum, per decade of having a coronary event, we know that being on a statin, so for me being on a statin, it would lower it to roughly 7.5%. If you extrapolate that over the next 30 years, so you add all those risks together, that means if I go on a statin, it will lower my risk of having a cardiac event by about 7.5%. And you can definitely argue that's a really good thing to lower your risk by that much. But the flip side of that is that I've got to be taking a drug every day for the rest of my life, and there's a 93% chance it will make no difference to my outcomes. That either I'll have had a cardiac event anyway, or I won't ever have a cardiac event. So we should probably be more honest and upfront with people about discussing risks when they have coronary calcification in the CT. How much calcification is there? What your risk factors are like? Is it justified to be in a statin? And do you want to take a drug for the rest of your life to lower your risk by a small percentage, and roughly what that percentage is? And that will vary depending on the extent of your risk factors, what age you are, what your blood pressure is, what your cholesterol actually is, how much abnormality there is in your coronary vessels. Have you had a previous cardiac event, for instance?
So it's a much fuller discussion, and presumably this is why a lot of people stop taking the statins.
People stop taking statins for a variety of reasons, because I view them a bit like taking out life insurance. You don't feel good for taking out and spending money on life insurance, but it does something for the future. The people on statins don't feel better for taking statins. We know that in some studies, there's about 40% of people stop taking statins once they're prescribed taking statins. And is that because there's a nocebo effect? And nocebo is the sort of flip side of placebos. Placebos is you take a drug with the expectation that you're going to feel better taking a drug. There's a lot of negative publicity about statins, and there is definitely a nocebo effect where people think that they're not going to feel well taking a statin. And so psychologically, they're more likely to stop taking it because of that effect. And there probably is there may well be a side effect profile associated with taking statins. So a lot of people stop taking them. A lot of people don't want to be reminded every day that they're taking a drug for future prevention, and it's easier just to stop taking it. So there is a attrition in the number of people who remain on statins.
And they are controversial, aren't they? I've heard radio programs on these.
They're still controversial. Yeah. I'm a cardiologist. You're not going to get me to tell you that statins are bad. Statins definitely reduce your risk of coronary events, but it's how much risk benefit there is. And I think there's definitely populations which are high risk, which we think that you really are definitely strongly recommended to continue to take a statin, because these do modify your risk substantially. But there's other populations where the level of risk modification is actually quite small. And if you're down in the 5% chance of having a cardiac event in the next 10 years, do you really want to take something that might lower it by 25%? Because if you've got 100 people in the room who've got that same risk factor profile, all taking the drug, one of them will not have an event because you put them onto the statins.
Can you tell when you meet someone out on the crag when you're climbing? Can you tell when chatting to them about their lifestyle, their fitness? Could you kind of get a fair idea of where their risk factor is?
No, not really. Unless they've got a cigarette in their hand.
You see, I just wondered that. I remember going back decades when the Conservative government was having all the GPs to try to do cholesterol, when that was a target for them and they were rewarded for it. This was in England. I remember my GP saying to me, I can tell when they walk in the door what the cholesterol score is going to be. And I just wondered whether or not, I mean, you can't tell, presumably in your clinic, otherwise they wouldn't be there. I just wondered whether these risk factors are more insidious, because there'll be people out there who think, oh, listen, I train 3 times a week, 4 times a week. I go to the gym, I ride my bike. I'm going to be all right, surely. And that's not necessarily the case.
Not necessarily. There's for cholesterol, for instance, there's some people they've got cholesterol deposits that you can see in their tendons around their eyes. You can see that they've got abnormal lipids simply by looking at them. But that's a very small subset. The majority of people, cholesterol is unseen.
Mm. And there's no way of knowing unless you get it tested.
Unless you're having your blood tested. There's a genetic condition, familial hypercholesterolemia, affects about 1 in 500 people. And unless you've got other family members who've got premature coronary disease and have had their lipids checked, you're probably not going to know about that unless you've had your lipids checked.
I'm just looking at what are in my notes. Fit and unfit, 20%. There was a coronary CT thing you were talking about, a study with 400 people. Fit as a baseline.
The other bit is, so if you do have you've been picked up as having coronary atheroma, whilst there's this very small risk of sudden death associated with exercise, so there is, when you're exercising heavily, there's a very small increased risk of coronary events. But the flip side of that is that regular exercise is undoubtedly beneficial for people. And they did a really good observational study in people who had coronary artery calcification scores greater than 400. And
that's a lot.
It is a fair amount of coronary artery disease. And split them into, well, they looked at people's baseline levels of fitness, how much metabolic activity, how much METs they could do of exercise, and split you into fit groups versus unfit people. And found that people who were unfit, your risk of having a coronary event if you had coronary artery calcification scores greater than 400 was around about 50%. Whereas the fit group of people is about 20%. So continuing to exercise undoubtedly is protective. And that's the sort of all the messages is don't stop doing what you're doing. It's really important to keep exercising across pretty much all populations of people with cardiac disease. There's a couple of rare cardiac conditions which we advise not to do a great deal of exercise with, but the vast majority, continuing to exercise seems to confer significant health benefits. And certainly for people with coronary artery disease, the risk of not doing something is vastly outweighs that very small risk of an event when you're pushing yourself doing heavy exercise.
In the second part, we're talking about people who've had an adverse cardiac event. I always thought event an odd word in such circumstances. We're talking about someone being given a diagnosis of atrial fibrillation or having had a heart attack, like our friend Duncan, who was one of the founders of the climbing gym in Inverness where we recorded this. He was advised to keep his heart rate below 134.
I'd like to say there's still variations in thinking across cardiology practice, and whilst Duncan's been told to keep his heart rate below 134, that's not the advice that I would generally give. So there is a variation in practice. The standard, there are bits which we universally agree on, and that is if you've had a cardiac event, if you've had a myocardial infarction, heart attack, the cardiac rehabilitation programs make a big difference to the initial recovery.
What do they do?
The cardiac rehabilitation programs is a team of nursing staff, physiotherapists that go through educational stuff and promote a sort of resumption of exercise. And these reduce hospitalizations, they improve patient recovery, they reduce and they reduce anxieties. So people get back to exercising sooner, going through a structured cardiac rehabilitation program. Once you're through that, so if we're talking, so the months after, so you've had a cardiac episode, I'll call them an episode rather than an event this time. The longer term recovery following that depends, well, there's the coronary artery process, which is similar to the discussions we've had about people who've been detected as having coronary artery disease. Most people who've had a cardiac event in the UK who will have an angiogram performed, and that applies to most Western countries. We know what your coronary arteries look like. The worst areas, the part that's caused a heart attack, is likely to be opened up by putting a intracoronary stent in the coronary artery to improve the flow beyond that. Now, a lot of what we do in terms of promoting what sort of exercise levels people should do afterwards depends on, is there a lot of narrowings elsewhere in your coronary arteries? What's the extent of that? And how much scar tissue there's been inside the heart? And I think that when I see people, I'm looking at three things when it comes to what do we do to reduce your risk of sudden cardiac death? Because sudden cardiac death can come about because you have a further heart attack. One of the plaques in your coronary arteries ruptures and causes a blockage. And we know the risk of that is low, but it can happen. And being on risk-modifying drugs or treatments or lifestyle changes that we discussed earlier is the way we tackle those. We'll look at whether there's a large chunk of thick scar tissue which potentially can cause rhythm disturbances
in the heart itself.
In the heart itself. So we call it ventricular tachycardia caused by scar. And we also look at whether there's an area of narrowing that is reducing the blood supply to the muscle beyond the narrow coronary artery, that may cause rhythm disturbances under levels of extreme exercise when people are pushing themselves. And so I think that for me, if people are keen athletic people and want to get back to doing exercise, and we know there's persistent coronary artery disease, I like doing a treadmill. Some form of exercise where we monitor your heart for both its rhythm and whether there's ischemia. Ischemia means a reduction of blood supply to the heart muscle. And seeing whether there's any signs of that as a guide towards your treatment. And if your arteries are otherwise okay and the blood supply is good into the blood vessels and no evidence of any rhythm disturbances, then I think a lot of people can get back to complete normal, full normal exercise rather than being capped towards an arbitrary heart rate.
So describe that to me. What would you see? How would you monitor the blood flow? I get that you put an ECG on them and you go on a treadmill, and presumably you get their heart rate to go up and up.
Yeah, that's right.
Usually, but how would you monitor the blood flow?
So it is looking at the ECG recordings. So
you can tell from that.
So you can tell on looking at the ECG whether there's shifts in the electrical patterns that imply that the heart's not happy. That it's getting a starvation of blood supply to the muscle beyond the narrow section.
Because you explained to me earlier that it's a perverse situation in that you're more likely to have an event when you are really, I'm still using the word now, you're more likely to have a problem when you are going for it and your heart rate's high, and yet doing that is good for you in the long run. Like immediate short term, it's not good, and long run, it's better.
It is, but
could you put that into better words than I could?
Well, probably. I think the way you describe it is actually fairly good, Simon. But it's the risk of pushing yourself very hard is actually still very low. So we see lots of middle-aged athletes doing the Loch Ness cycle event every year. The number of people that have a cardiac event, there have been one or two, is actually very low compared with the number of participants. Same with things like the London Marathon, but these things get a lot of publicity because it's devastating is for athletic people to suddenly present out of the blue with something's happened to cause a sudden cardiac death or major rhythm disturbance or a cardiac event that's when they're exercising. So they get a lot of publicity for these, whereas the bits that don't get publicity and the bits you don't hear about is that people who are not doing much exercise who then get their cardiac events afterwards.
But it's more that idea though that if you are training, do you train, can you still do high intensity?
I think so.
Yeah,
I think so. In the majority of people. Now this does vary depending on how much muscle damage has been, what the cardiac function is like. But for most cardiac events that we see, there's been a small amount of muscle damage. The heart muscle still pumps normally. The amount of scar tissue can be very, very small, that sometimes we can't even see the amount of scar because it's so small we can't pick it up on our current imaging techniques. And for people who've got limited amounts of scar, I think a full recovery in the returning to complete normal levels of exercise after the initial period, after you've been through that period of cardiac rehabilitation, is entirely appropriate for the majority. And I think that's broad advice. Of course, that any individual watching this who's had cardiac events should see their cardiologist or general practitioner and discuss the individual level of risk. But for the majority of people, I encourage people to get back to complete normal, full levels of exercise, including some of the high intensity stuff, because the high intensity stuff is, as we've alluded to in several of your previous videos, is very beneficial as long as it's kept under moderation. You don't want all your stuff to be high intensity. Atrial fibrillation doesn't kill people. It's a nuisance arrhythmia, it's unpleasant, and it reduces your ability to exercise when you have it. Now, the majority of people who develop atrial fibrillation, the initial bits of it is short bursts. It's called paroxysms. So that you get some atrial fibrillation, it then settles, and as time progresses, the bursts get longer and they get more frequent. So the initial part of it, I think it depends on how much atrial fibrillation you're getting as to what sort of modification you want to do about things. We do know that in people who do a lot of intense exercise, that atrial fibrillation is more common. And I think that in people who are exercising very heavily, who present with paroxysmal atrial fibrillation, we'll often have some discussion with them about what they want to do. Do they need to carry on exercising as intensely? Do they want to cut back their exercise slightly to modify the amount of atrial fibrillation they're going to get in the future? Once you start getting atrial fibrillation, the majority of people, it does progress over time. Once you've had your first episode, you're more likely to the next ones be a bit longer and the intervals between them start becoming shorter, i.e. you're going to get more atrial fibrillation. And there comes this point where there's a discussion about what treatments do we offer. And those treatments are based on how much these things are impacting your lifestyle.
Right. So can people get back to full fitness after some of those treatments?
Well, in between the episodes of atrial fibrillation, initially you may get an episode every year, every 18 months. Right. And in between those episodes, you can be exercising completely normally and have no issues with it. Some people, we see people who have atrial fibrillation, and some people get very minimal symptoms from their atrial fibrillation and can carry on exercising at a very comparable rate to what they did before. Unfortunately, there's some people who are debilitated by atrial fibrillation, and when they get the episodes, they find that they are incapacitated, unable to perform any significant levels of exercise. And the advice we have on these people is really depending on the level of symptoms, how much trouble you're getting versus what we can do to modify it. So a lot of athletic people who get recurrent increase in frequency of atrial fibrillation, a lot of people don't like the drugs that we potentially can put people on, because beta blockers are our commonest drug that we use in atrial fibrillation. And a lot of athletic people struggle when they're on beta blockers because they cap your level of aerobic exercise to reduce your maximum heart rate. So once you're getting more frequent, it's consideration, do you do ablation procedures, which is an electrical burning or freezing of parts of your heart to create small scar lines to make it less likely to get atrial fibrillation in the future. And a lot of people, if they find they are debilitated by atrial fibrillation, will go on and have pulmonary vein isolation. That's the electrophysiological ablation procedures to reduce the risk of it happening in the future. And what we don't know is the people who then carry on exercising at high intensity after pulmonary vein isolation, are they more likely to get breakout other atrial fibrillation arising from elsewhere in the future? Yeah. As it stands at the moment, there is no evidence to show that people who carry on exercising are more likely to get problems after pulmonary vein isolation than people who don't exercise.
Is there any evidence to suggest that people who have these intermittent episodes of AF, if they keep exercising, that will increase their frequency of AF?
I don't know, actually, Simon. That theoretically, you'd think that if the substrate, the thing that's caused it, has been high intensity exercise, you'd think that there's going to be is more likely to progress with people who continue to exercise.
Off that high intensity.
So back off the high volume, high intensity
Let me ask you the question that's kind of bugging me, because the easiest thing for me to film is me. And that is, and the answer to this is, I think, is I don't know. But as you know, as we've talked about it, I've had a couple of little episodes that I've been trying to work out what it is. You've advised me. I'm just wondering how common it is for blokes in their 60s, in their 50s, 60s, who to get these. That probably don't. I went to my GP with it, but I've not actually followed up much with that. I'm still getting them occasionally, and I've worked out how and why, what triggers it. And so I'm trying not to do that. And I'm just wondering, do we know that there are people out there watching this who might be going, yeah, I've been feeling a little funny too, but it'll just be one of those things. It's probably anno domini, it's just my age.
So we do have some data on this, which is that palpitations and irregularity of the heart rhythm is extremely common. That the ectopic beats, awareness of ectopic beats. Now, most of us get ectopic beats. If we put on 24-hour rhythm analysis where we attach an ECG to people for a 24-hour period, we know that 7 out of 8 people have got some form of ectopics or rhythm disturbance during a 24-hour period. The majority of those people aren't aware of. Now, what we pick up, what your brain picks up as signals and alerts you to, depends on how much your brain is listening into what you're coming from the heart. So that we filter out a lot of the signals. And it's actually very hard to know how much people present with. We know that I don't see that many people in hospital clinics who are coming with palpitations, in sort of middle-aged athletic people who are just aware of the intermittent ectopic beats, because they're very common and most people rationalize and think these are short-lived, I don't need to do anything about them. If you're getting a sustained period where for minutes that you're aware that the heart's jumping around, it's erratic, there may be something more in that. So I think one of the most important things that we want to emphasize, though, is that for people is that the risks of exercising are vastly lower than the risks of not exercising. All the data shows that people who are sedentary and people whose fitness levels are lower have much worse outcomes than people who continue to exercise. And if people are anxious about continuing to exercise once they've had a cardiac diagnosis, well, you should actually be more anxious about not exercising, is I think one of the fundamental messages to put forward, Simon.
Huge thanks again to Dr. Clarkson. If this has been helpful to you, you might consider buying me a small coffee. It's a little payment that helps keep this show on the road. I'm Simon Willis. Thank you for listening and for watching. Until next time, goodbye.